Hello and welcome to another edition of the Osteopathic Lyceum podcast. We're going to touch on the general topic of variance between patients and use a few examples to understand how you might see that and why it's important to use a framework as opposed to a checklist in approaching patients. So a checklist would look like a technique set. When you hear a word associated with whatever you may diagnose that patient with, you would go through that particular set of steps, versus assessing that person as they present right now and interacting with them based on how they respond to what you do right now, right? So that would maybe map better, or that does map better to what I would call a heuristic-based framework, where the other one would be a procedural checklist, which I am not in favor of. So if we take the initial example that I'll use of the theory of constructed emotion put forth by Dr. Lisa Feldman Barrett, so you would have heard me talk about this before if you've been hanging out for a while. What is identifiable about emotions is that there are words or category words such as anger. And if you look at that and you look for any stable signature within an individual, you'll find it within an individual sometimes, but if you look between individuals. So if you hear the word anger, somebody reports anger, and then you check their galvanic skin response or their surface EMG or their perspiration, their respiration, their heart rate, any brain activity, you'll notice a wide variance of measurements under the term anger. So maybe a better way to say it is when somebody says they're angry and you measure any of those things, you will not see the same thing. You'll see a wide variety of responses. You'll see some crossover, but it won't be so stable that you could predict that when you see a particular spike in perspiration that it means anger. You can't track it that way. So we have words that you could call categories or constructs, right? So with the theory of constructed emotion or built emotion, you will have a wide variety of measurable responses physically, but the interpretation of those physical signals and then the output of the word anger, you'll have a bunch of stuff that leads to that. It's highly variable. If you look at things such as response to pharmaceuticals, you will see that while there is a standard dosing chart based on varying things, that each individual will respond somewhat differently. Some people respond better to something like Tylenol. Some people respond better to Advil under the exact same reported circumstances, something inflammatory, something like a headache. Some people just like respond better in their interpretation to Advil versus aspirin. I know of somebody who, when they take melatonin, they wake up. So you could use the term paradoxical responder. If you are working in hands-on manual therapy, please excuse me as I clear my throat. If you're working in hands-on manual therapy, you will find that using the same move, the same technique, the same approach will variably impact different people. So some people need more pressure within the same move. So if you take something such as leg rotation or supine leg rotation, so the patient's on their back, you bend their hip to 90 degrees and you essentially let their knee hang at soft ischio approximation, so where their calf and their hamstring are hitting, and then you shoulder it or you wrap around it and you start to do what would be termed a leg rotation or supine leg rotation. The distance that you have to travel from one person to get anything. Sorry, I thought I saw something funny on my camera. Please excuse the mild interruption. But yeah, the amount of movement that you'll have to generate in one person to get a particular response, and if you do the exact same amount of movement because that's the right amount of movement, the other person or the next person or the next set of people will not have the same response. It'll be highly variable. Some people need more range. Some people need more pressure. Some people need less range. Some people need less pressure. It's going to depend. If you have something in hands-on manual therapy to guide your decision-making based on how far, how firm, how fast, how slow, then you can make these adjustments as you go. That ends up being the barrier concept, at least in osteopathy. In other professions, different discussions will be had. But osteopathy's hallmark is the barrier concept. So the way that I've termed it before is don't make them say ouch. That's the heuristic. But the way that over time, as I've thought about this and spoken about this out loud and recorded, I tend to now say avoid protective responses. So don't make them say ouch is a nice proxy for avoid protective responses. Those protective responses would be sudden contraction in relation to sudden movement. Right? So you speed up too fast, or maybe even if you're going too slow, the way you get to a certain point and they jump, right? So there's a sudden response, sudden contraction, active contraction. You can have a sudden face made to your movement. So, a grimace with some pull or pull away. You can have an audible sound that relates to an abrupt sound in response to movement. So if it's abrupt, that's the thing. It's not the sound itself. It's the fact that there is one abrupt or several abrupt responses that can be felt, seen, or heard. So multisensory integration becomes important, and the way that I talk about multisensory integration as a heuristic is keep your eyes and your hands on the prize, or your hands and your eyes on the prize. Either way, it still works because you need to combine at least your eyes and your hands. Audition, or the auditory sense, is exceptionally important. So if you can feel, hear, or see a sudden response in the patient, you've done something that has elicited a protective mechanism to some degree, whether it's because something they're thinking, or because of something they're feeling, or the kind of crossover of both. So you need something to judge against. If you use the barrier concept and you talk about going direct or going into the restriction, short of making them say ouch, or short of any protective response, then you're okay, as long as when you go in that direction of resistance, there's no protective response. So you can add tension to the tissue, but it shouldn't tighten up. It shouldn't tighten up to a point that feels like it's getting close to generating a protective response. The way that you would learn that is you would do something on a bunch of people, you'd get to a certain level of tension, and a lot of them would start to pull away or say ouch or jump or do something of that nature, make a face, grimace, something like that. You do that to a bunch of people, you start to figure out what that's like to you, you integrate that, and you start to work forward, staying somewhat short of that. You can go through the range, the restricted range, but you can mobilize whatever leverage that you're using so that as you go through that range with the structure or structures you're trying to go through it with, that it doesn't feel particularly firm at all. So you can, let's just say you're working on something like the lat, the rotator cuff-ish, or the tricep. Often, if you heavily internally rotate the arm, let's just say you're trying to get shoulder flexion. Often, if you heavily internally rotate the arm and then generate the shoulder flexion from there, a lot of that rotator cuff tissue stays relatively soft. The tricep tends to stay relatively soft. And the same can be said in a lot of cases for the pectoral tissue. If you want to work on the pectoral tissue, often if you generate some mild flexion and internal rotation, you can get a lot more flexion out of those things that might be restricting that shoulder flexion or that shoulder girdle flexion, relatively speaking. Now, it's not always that. It's a general range to consider. It's not always that. And that's why we were talking about the variability. And a lot of times I'll say a little bit of this, a little bit of that. You need a little this, you need a little that. Because everybody's so different, right? So some patients will request very firm contact. They will request what they interpret as very deep pressure. Sometimes somebody will say that you're applying very deep pressure, but you're barely touching them. All of these variances in responses are important to understand, important to acknowledge, and important to work with. Your signals as to whether or not you're doing osteopathy properly are whether or not you're eliciting those protective responses. So to sort of close the loop on the direct concept or the barrier concept, direct is going in the range of restriction with no protective responses. So you can add tension to the tissue, but you don't want to add too much. You can keep the tissue relatively soft and go through those restricted ranges, or you can go indirect. So if the patient does say ouch, you just make all the soft tissues in the area soft. You're aiming to make those soft tissues soft with the underlying plausible mechanism, the reduction in sensory information from the region. The reduction of sensory information should reduce the motor output to the area, the requirement or the call for protective responses, and mostly mediated by the muscle spindle. So you're trying to shut or slow down the muscle spindle firing. So if you can't see this, and you need me to explain it, but if you see my hand is sort of going at this rate. So if we consider hypothetical muscle spindle firing at something like that, what we're looking to do when we make the soft tissue soft is go from to that if we slow down that firing frequency, hypothetically, or as a plausible mechanism of action, then the motor output to that muscle should slow down, or the signal to generate tetanic contractions should reduce. Therefore, you can work the region without the protective response. You can get more of the range that you're looking for. You can make the attempted thinking claim or cognitive claim that something's happened to the mechanism of the muscle spindle whereby sensory information is slowed down, therefore motor output. So the gamma, I believe the proper term is gamma gain, but I may be messing that term up. You've intervened with that in some way. But what you notice, whether or not that is the thing that's actually happening, is you notice that when you get the soft tissue to not really respond to what you're doing in almost any way, you can get a lot out of tissue. The way that you do that, though, the amount of pressure, where you put your hand, that's highly variable because these patients are highly variable. So as superficial mechanisms, we touched on things like the theory of constructed emotion and how one word can have varying presentations in many people: anger, happiness, sadness. People can have very strong emotions on the inside and almost no external expression on the outside, but you'd never know unless you know that person. And you know them reasonably well, so you can see their patterns over time. You can understand people a little bit better when you see them over time in multiple circumstances, and you can see the pattern that they'd present and ask them questions for feedback, and you sort of tune into them better. Whereas if you make any form of assumption, and as I've said before, about anybody's emotional state by their external presentation, you're probably wrong most of the time, unless you know them very well. If you look at, say somebody comes in to present for hands-on osteopathic treatment, and based on, say, phenotype, right, how they visibly look outside, especially, say, with respect to size, gait, other movement patterns that they display on the way in, if you set your mind to what you're going to do as a result of that and you don't pay attention to how they respond on the table, you're probably going to be wrong. A lot of people will look one way and move a very different way. A lot of times people will have superficial concerns, say, about the size of the patient. If the patient is considerably larger than the practitioner will often think that the limbs are going to be heavy and hard to move, and the person's going to be immobile, and it's going to be a really hard time. And you're looking at the difference between the practitioner and the patient. If you have a very small practitioner, then everybody sort of looks that way in the general population to them. However, when you lift their legs, they may move quite easily. They may not feel all that heavy to you as a practitioner, even though that patient isn't helping you. So you could tie this all together, or this discussion all together, with don't judge a book by its cover. Actually open the book and take a look at it and see what interacting with that book is like, or what reading that book is like. It's a nice old sort of classic wisdom piece where you have to pay attention to the thing that you're doing. You have to figure out how you interact with it to do it best. So take this as acknowledgement of the variance between people. I give you the concept of the theory of constructed emotion, the concept of a variety of response between individuals to the same pharmacological interface, so the same drug interface, the differences in the experience of an osteopathic manual practitioner when working on a variety of patients. Because of that understandable, easy to see variance, it becomes much more important to tune into the person in the moment, as opposed to have a pre-recorded set of procedural steps to go through when somebody says shoulder pain. You can have, I would actually suggest, and this is maybe where I want to clarify, I would suggest that you have a very predefined set of assessment steps for anybody who comes in, regardless of complaint, and then you have sort of a set of assessment steps in a localized area where you find a problem or where the person complains of a problem. So somebody complains about shoulder pain. You have your general assessment that you find what you need to find, broadly speaking. And then when you get to the shoulder, you have a set of steps for assessing the shoulder so you don't miss anything. Or what you do miss, you know you missed. And then how you work on them is dependent on what you found and how they respond subsequent to the hold you choose. Whatever hold you choose, you use the barrier concept to not make them say ouch, which means do not elicit protective responses, which means prior to that or staying away from it is moving that person in a way that doesn't add too much tension to the region, that doesn't move too fast or too slow, or that generally removes tension from the region, muscular tension specifically. So if you can sort of start to sew all that together, then you're probably going to be properly responding to the variance in between individuals. The framework does that better than the steps. Now, granted, when talking about assessment, it is more important to have a set of steps for assessment. You want that to be pretty regimented. But treatment, once you've found what you happen to find in that individual, it should respond to how that individual responds right now in front of you on the table. And hopefully, speaking about this, reiterating this in this semi-podcast or podcast format. Primarily, I do this through video, but if you're listening to this on audio only, then that's fantastic. But hopefully, hearing this in many ways, hearing me speak at this from different angles, hearing me bring in pieces of information from different angles to talk about this, to provide different examples of it, of the variance, and then to watch some of the demonstration videos that we have on the YouTube channel on the Osteopathic Lyceum, then you can start to sew it together. So you can see what it looks like, you can hear what it's supposed to be like, you can start to integrate those pieces of information, you can practice your own way, you can set a particular desired outcome, and as many people as you happen to have the opportunity to interface with on the table, say in patient lateral, I want to work on the shoulder girdle behind the patient, and I don't want the tissue to jump at all. Now you have your very constrained set of intentions. You go out and you try a bunch of different holds, a bunch of different movements on a bunch of different people, and the feedback starts to come in, and you start to understand how to do that better. So essentially doing everything on purpose, which is then going to relate to another one of the heuristics, is be organized. So your assessment heuristic is be organized. Do things in a particular order, start to finish, start somewhere, end somewhere. Don't jump around all over the body, just so that you can automate and be regimented about your assessment, knowing what you've missed on purpose so that you can minimize cognitive load, minimize redundancy. Then whatever areas you find restriction in, you have another set of steps when you zoom into those areas, whereby you can more appropriately assess them and choose a better hold. And then you know, because you've purposely practiced all those things over and over and over, what it's like to move at a certain pace. And then you start to be able to tune into each individual at a, say, quicker rate of speed because you've done this so many times on purpose. You set your constraints with the framework. You figure out the details that work between you and that person based on the fact that you've done it with a bunch of different people over time. So touching on, as I said, the variance between people, but then also how you learn or how you approach figuring out how to deal with that variance by doing things or the same thing with a bunch of different people, seeing how they all respond, integrating that as feedback into how you approach a new individual. So the more times you do something on purpose, the more you sort of figure out how to do it with a new person faster. Hopefully that all makes some sense. Thank you for sticking around. I look forward to talking to you again soon. And don't forget to go and look at a bunch of demonstration videos so that you not only hear these ideas, but you see what they look like to some degree on live demonstrations, or at least teaching demonstrations. So thank you again, and we'll talk again soon.